Hi everyone, my name is Dr. Jennifer Pearson. Thanks for joining us. I am new faculty at the University of Nevada, Reno, School of Community Health Sciences. I'm in the Health Administration and Policy Department. And I'm also a Nevada native. I graduated from Reno High School in 1998, left for various kind of levels of school in Peace Corps, and now I'm back. So I'm really happy to be here. I'm happy to be speaking with all of you. And today we're going to talk about e-cigarettes and federal regulation. So once we get, there we go, here's the screen. So I'm going to ask you as I speak, if you wouldn't mind, I'm going to try and leave about 10 minutes at the end of today's talk for questions. But as I'm speaking, if something comes to you, if you could just use the chat box. And then what I imagine what will happen is a bunch of you will have questions that will kind of all be in the same area. And we can look at those and start to answer those during the question and answer session. So let's get started. So the topics for today's talk, I'm not going to assume that everyone here knows about the burden of cigarette smoking and tobacco use in the United States, so I'm going to go over that briefly. Then I'm going to introduce you to the Food and Drug Administration's authority to regulate tobacco products. And then I'll apply that authority to specifically to e-cigarettes, and we'll get into some basic e-cigarette research. I should also say, so my credentials, I finished a PhD in public health at Johns Hopkins University in 2011. I am PI, or principal investigator, of 2 studies funded by the National Institutes of Health, National Institutes of Drug Abuse, both on e-cigarettes. I'm also an associate editor on the recent Surgeon General's report on e-cigarettes among youth and young adults. I also focus somewhat on tobacco products that are labeled natural, organic, and additive-free, but that won't be the topic of today's talk. So I really am pretty focused on e-cigarette use and have been since, I'd say, 2009. So the burden of smoking. Cigarette smoking is the leading cause of preventable death in the United States. It causes 480,000 deaths a year. That is both primary, so smoking, and also secondhand smoke exposure. That includes also deaths from fires, deaths from sudden infant death syndrome. And I think sometimes a lot of us think, well, smoking is solved, you know, because we're certainly doing better than we ever have in the United States. But still, 480,000, nearly 500,000 people each year is, in my opinion, utterly unacceptable. And this is from the most recent General Surgeon General's report. So this was the 50th anniversary report from a few years ago. And you can see all the cancers and chronic diseases that are caused by smoking. The red ones were newly associated with smoking as of 2014. So you see it's just innumerable causes of disease from smoking. Tobacco is also a huge problem globally. As the globe becomes richer, people move away from being from causes of death from infectious disease, and we move towards chronic disease. And the estimate is, as of right now, that tobacco could kill 1.2 billion people globally by 2100. Smoking is absolutely a public health crisis. It is overwhelmingly caused by cigarettes and other combusted tobacco products or other products that are burnt. It is estimated that 5.6 million of today's youth will die prematurely from smoking. And in Washoe County, where we are at this very moment, almost 850 out of 100,000 deaths a year are due to smoking. It's almost 20% of deaths among U.S. men and almost 16% of deaths among U.S. women. So, you know, I'm sure a lot of you are health providers, and you see this every day, that smoking is truly a public health crisis. It's also a social justice issue. So we really see that smoking is, well, tobacco marketing availability, and the lowest prices are concentrated in poor and minority neighborhoods. You can see here, oh, can I turn this on? One moment while we turn this on. 10. Okay, there we go. You can see here that this is the relationship between level of education and the prevalence of tobacco use. And you see the folks with the least education, so people who either have no high school diploma or a GED, have the highest percentage of smoking, and then you see it decreases as your education increases. Same thing here, annual household income. You can see that people making the most money, over $100,000 a year, 12.1% of them smoke, as opposed to people making less than 20% of a year, 32.2% smoke. So you can see a clear gradient relationship between smoking prevalence and income. A lot of people say, well, smoking is solved, but really what's happening is it's being concentrated in the groups that are least able to effectively deal with it. So like I said earlier, we see that more tobacco retailers are near schools in low-income areas and in other areas. We see that individuals with mental illness account for 46% of cigarettes sold in the United States. That is a remarkable amount of consumption. And there's actually some people think that nicotine, people are essentially self-medicating with nicotine, and that smoking helps alleviate some of the negative feelings, both physical and psychological, associated with depression and anxiety. That's why we're seeing such concentration of smoking in those populations. And then we're also seeing some significant targeting of certain groups. For example, LGBTQ young adults are nearly twice as likely to smoke as their straight peers. And I want to just make sure that we're all clear also that, you know, a lot of these statistics are attributed to tobacco use, but according to the Surgeon General's report from 2014, the majority of deaths are caused by cigarettes and other combusted tobacco products. And they say rapid elimination of their use will dramatically reduce this burden. So as public health professionals, we are working in a world with limited resources, right? And we can't do everything at once. And so what the Surgeon General here is suggesting is that we really need to focus on the thing that's causing the overwhelming amount of death and disease, and that is cigarettes and other burnt tobacco. So as an aside, before we move forward, I just want to make sure that we're all on the same page with some terms that I'm going to use. So, you know, we're going to start talking about e-cigarettes, and it's not always clear what kind of terms you're supposed to use for what. So when I say smoking, I mean combusted tobacco use, like cigarette smoking, cigar smoking, cigarillo, hookah, little cigar smoking. Burnt tobacco produces smoke. However, I'm not going to use those terms when I refer to e-cigarette use, or perhaps also ENDS use. People say that, electronic nicotine delivery systems. You might also hear ANDS use, alternative nicotine delivery systems. People also say vaping, or vapes, or vape pens. This is all the same thing. It all means just to consume nicotine using an e-cigarette, or whatever you want to call that thing. These products do not produce smoke. They produce an aerosol of nicotine in like little bitty particles. And it's kind of commonly called vapor, but it's not vapor. It's not water vapor. It's technically an aerosol. So I just want to make sure that's clear. If I say smoke or smoking, I'm referring to burnt tobacco. If I say vaping or e-cigarette use or aerosol, I'm referring to e-cigarettes. Okay. So now we're going to move on and talk about FDA authority to regulate tobacco products. So this is where the magic happens. This is the FDA. And it's interesting. So the FDA has lots of different centers associated with it. And these are just three kind of the big ones that you might have heard of if you even think about the FDA ever. The Center for Drug Evaluation and Research, this is the place where you're always hearing about, you know, FDA approved this medication. Well, that's that okay? These folks work on medical devices. And then, if you ever hear about food recalls, for example, salmonella outbreak in spinach, that's these folks. And there are other offices and centers in the FDA, but this is kind of, I think, how most of us think of what FDA does on a daily basis. After 2009, we got this new center, the Center for Tobacco Products. And I'm going to explain to you a bit what they do and how they were created. So they were created as part of the 2009 Family Smoking Prevention and Tobacco Control Act. This is a picture of President Obama signing that, that legislation in 2009. And what this did was it gave FDA authority to regulate the manufacture, distribution, and marketing of tobacco products to protect public health. And this was a new thing. Before 2009 in the United States, no one agency or authority regulated tobacco products. There were some regulations on things like cigarette pack size, obviously taxes. We had restrictions on age of sale, but the actual product itself was not being regulated. And part of this law created the FDA Center for Tobacco Products, or CTP. And initially the law was limited to cigarettes, roll your own tobacco, and smokeless tobacco, but then FDA expanded their authority to all tobacco products, including e-cigarettes, in 2016. So FDA can do all kinds of stuff when it concerns tobacco regulation. What they did immediately was they banned flavored cigarettes, smokeless, and roll your own tobacco, except for menthol. So I don't know if you remember, before 2009, you could get pina colada cigarettes or cherry cigarettes, or I don't know if you remember the clove cigarettes. Or those are no longer legal. The idea was that they were unusually attractive to youth, and therefore they were banned. These authorities also require some changes to the cigarette and smokeless warning labels, which are still somewhat in progress. It requires disclosure of ingredients in tobacco products. So before this law, there was no requirement that companies disclose what's actually in their products. It requires that any modified risk claims must be supported by science and must go through a process where FDA does not approve, but allows marketing of modified risk claims. And so part of that, upon passage of this law, was it banned the descriptors light, low, and mild. So no longer, it's not legal anymore to have a light cigarette. It can't say light on it. What ended up happening, however, was the companies just used colors to convey the same thing. So instead of light, we now see silver. So I don't know how effective that was. It also just generally allows for regulation of tobacco product characteristics and requires pre-market certification of products, meaning that tobacco companies can no longer just put out whatever they feel like on the market. They have to show that the product will not significantly affect public health. Essentially, that it's not a huge change from the status quo. So the Center for Tobacco Products makes decisions about regulation of tobacco based on what's called the public health standard, which has 3 parts. So first, they have to think about the risks and benefits to the population as a whole, including both users and non-users of tobacco products. So both smokers, for example, and non-smokers. Then they have to ask themselves whether there is an increased or decreased likelihood that existing users of tobacco products will stop using such products. So we want that, right? That would be good for public health. And then we have to ask ourselves whether there is an increased or decreased likelihood that those who do not currently use tobacco products, most notably youth, will start using tobacco products. So those are the 3 things they have to think about whenever they have a new tobacco product application in front of them, or whether they're considering using some of their authorities to perhaps do something like ban menthol, which they could do, or decrease the amount of nicotine in cigarettes to non-zero levels, meaning just not to 0. Next, there we go. So we can use the public health standard as a guide for research. We can think about there we go. We can think about the harm the population harm attributed to, there we go. The population harm attributed to tobacco use as a equation where we have appeal. So that's like product characteristics that might get someone to start using a product. Abuse liability are the characteristics of the product that make someone want to continue using despite negative consequences. So that's like its ability to deliver nicotine, for example. And its toxicity. So, you know, we could have a product that has high abuse liability, so it delivers nicotine really well, but it's not particularly toxic. And that might have a different population harm than a product that is both very addictive or has a very high abuse liability and is also very toxic. And I should say as an aside, nicotine is not particularly harmful on its own. So you can think about nicotine replacement therapy, right? The patch, the gum. You can actually buy these things over the counter, right? There's no restrictions on this. That's because the nicotine is not the thing that causes the disease, though there might be a little bit of cardiovascular effects. It's the delivery system. So it's the burning tobacco leaf that is the huge problem here. So we think about e-cigarettes. This is a very interesting and complex public health problem because, and we'll get into this, e-cigarettes are not just one thing. So they have different levels of appeal and different abilities to induce dependence, or they have different levels of abuse liability. They also have somewhat different levels of toxicity. So we'll get into that more also. So when someone asks you, are e-cigarettes all bad or are they all good? They are neither. You say no. Or you say yes. Because it's not a simple answer. And we're going to talk about that. So my question and the question of folks in tobacco science is, how do we keep people in these nice green circles? So think of the population. Population can be in any one of these circles, right? And they've got little arrows, you know, they can go over here and start smoking. They can go over here and start using e-cigs, or they can stay in their little green circle. And obviously we want everyone to stay here, right? We want them to be non-users. But if they manage to find their way down into the cigarette use category, one of my questions for my research and my work is, how do we move them either to the less harmful nicotine products, which I'll show you why I think that they're less harmful, or, you know, preferably, how do we move them into former use? So this is number 2. If I had this is number 1. This is what we want, definitely. We want everyone to hang out up there in non-current use. If they're going to move either here or here, then we want them to end up down here. But if they are unable or unwilling to get into the former use category, then it is better for them to be here than to be here or here. Okay, so from a public health standpoint, you know, I would love everyone to end up in former use or to stay in current use, but we have a very diverse population of people with different things going on in their lives and different abilities and different points in their lives, and so we need to acknowledge that. And I think a lot of you as providers probably have experienced that yourselves, right? You are with someone, you're advising them to quit smoking, and they're saying, you know what, it's just not for me right now. So we're going to skip over this. So now I'm going to talk about FDA regulation and apply it to e-cigarettes. So a little bit of in the weeds history here. So in 2009, FDA denied import of e-cigarettes from Smoking Everywhere and Enjoy. These are 2 e-cigarette companies. And what they said was, you cannot import these because they are an unapproved drug-device combination intended to help treat withdrawal symptoms of nicotine addiction. And if you want to import these, you have to go through the drug evaluation side of FDA, and you have to essentially be treated like nicotine patches or Chantix. And these companies, of course, were like, no, we don't want to do that. We just want to import our stuff and sell our stuff and make our money. So they took FDA to court, and the court ended up deciding in favor of the e-cigarette companies. Essentially, they said, just because something has nicotine doesn't mean it's supposed to be used for cessation. However, that was funny because a lot of people use them for cessation anyway. So it's kind of funny. So this is how e-cigarettes became regulated as tobacco products, even though, as you can see, there's no tobacco leaf in them. Sometimes the nicotine is derived from tobacco, but for me, ideally, I would like to see some sort of modified regulation where they are treated more like a drug or device than a tobacco product, so that we can really start working on treating these things as people are using them, which is predominantly as cessation devices. But we are in this situation, so we're going to work with it. So, like I mentioned earlier, e-cigarettes are not a single product class. So when someone says, do e-cigarettes help people quit smoking? You say yes or no, because the answer is, it depends. So we have a few different kinds. We have this first generation, which are called cigalikes by us researchers, and that's because they look like cigarettes. And they have these little bitty batteries. So let me go back. So like on a cigalike, this is the battery, and this is where the fluid is, the nicotine-containing fluid. And these little batteries don't do a great job aerosolizing nicotine, and therefore the nicotine doesn't get all that deep into the lungs, and therefore it doesn't get absorbed into the bloodstream, and thus smokers do not find it particularly reinforcing. It doesn't do a good job alleviating withdrawal and craving symptoms, and people who try these often abandon them and say, this is not going to help me. Second generation, these look more like markers, like big Sharpie markers, and they often are what we call an open system. So you can see here, this part right here is the tank, and you can unscrew that and put in whatever kind of nicotine fluid you like. There's a wick in there, there's a coil that heats up. There's a wick and a coil that heats up in here too, but you can actually see it here. And these things tend to be a little better at delivering nicotine, and therefore tend to be a little better at helping people quit smoking. These products are also products that people can use to vape cannabis. So we need to remember that it's not really these so much, though you can buy some pre-made cannabis products that do look like this, but it's mostly these products that people use to vape cannabis. We also now have what we're calling the third generation. Sometimes they're called personal vaporizers or mods. And these are products that are pretty sophisticated. You can change the wattage, you can change the resistance on the coils, so you can change how hot they get. You can change how much visible aerosol people produce. Some of them have like puff counters on them. Some of them can link via Bluetooth to your phone. I mean, they're pretty sophisticated, and they can get pretty big too. This down here is actually a e-hookah that you can see these this like right here. This is like a mouthpiece. And this would be a mouthpiece. And then we have what I'm calling fourth generation, though I don't even know if this necessarily even belongs in the e-cigarette category. And a lot of you are probably becoming aware of a product called Juul. It's very small. It looks like a thumb drive or a pen drive, whatever you want to call it. And it has little cartridges. It's not an open system. It's a closed system. And it uses nicotine salts. These other products use nicotine in a propylene glycol and vegetable glycerin solution. But Juul uses nicotine salts, and it is either the second or first most popular e-cigarette on the market right now. It went from nothing to quite a lot of market share in about a year. I'm very interested to see what happens with this product because it delivers nicotine very well. So smokers who are unable or unwilling to quit find this stuff very reinforcing, very satisfying. Unfortunately, if you have a product that is satisfying to adults, you also have a product that is satisfying to kids. And that is a problem, especially since these things are small. They are easily concealed. So as you can see, different populations will have different public health effects, right? So something that might be good for one population could be bad for another population. And that's why I say this is a very complex issue. There's no one-size-fits-all answer to how we should deal with these products. Okay. So e-cigarettes, I'm going to make a case here that you should think of e-cigarettes as being much less harmful than cigarettes. So first of all, cigarettes have 69 known human carcinogens, 4,000 chemicals. You're inhaling tar, you're inhaling carbon monoxide. I can't think of a single consumer product that is worse for you than cigarettes, okay? They blow everything else out of the water. They are terrible. So it is somewhat a low bar, or a high bar. It's easy to have a consumer product that is less harmful than cigarettes, right? However, e-cigarettes, depending on the type of e-cigarette, are much less to significantly much less harmful. So these products have, most of them have nicotine, not all of them have nicotine. They have propylene glycol and vegetable glycerin, which are humectants. They do have toxic constituents, such as tobacco-specific nitrosamines and heavy metals, but at much lower levels, somewhere between 9 and 450 times lower than tobacco smoke. We also know that some flavors are cytotoxic, meaning that if you have cells in a petri dish and then you bathe the cells in nicotine fluid with different flavors, that it will kill the cells. So like cinnamon, for example, is cytotoxic. Flavors that have kind of a buttery flavor can be cytotoxic. So we want to use regulation to remove those from products because that's simply unacceptable. We don't, that's low-hanging fruit. We can get rid of that. So here's just one example of a study that was comparing biomarker levels. So these are all some, well, not, there we go. These are all some well-known biomarkers of harm from smoking, from tobacco use. And you can see they're comparing smokers to former smokers. And then within smokers and former smokers, they have those groups divided into two groups. So here we see dual cigarette and nicotine replacement therapy users, such as patches, gum, inhaler, etc. And then here you see dual cigarette, e-cigarette users. And you can see, just looking across the two groups, you can see there's really not much of a difference between their biomarkers of harm. In some cases, they're a little higher, but they're statistically significantly similar to each other, I think in every case. So if you continue to smoke, using e-cigarettes or NRT will not improve your biomarkers of harm. But if you just look at former smokers, there's a different story here. So yeah, thank you. So looking at just NRT only users, so once again, those are people who are using patches or gum, so they're former smokers who are still using some form of nicotine replacement therapy, and we're comparing them to people who are only using e-cigarettes. You see across all these different categories, biomarkers of harm, you see similar or even lower biomarkers of harm for the e-cigarette users compared to the NRT users. And remember, NRT is FDA approved, smoking cessation, available over the counter. Anyone can go in and buy it. So this to me is a good indication that at least on the short term, e-cigarettes are about as harmful as NRT. We really need the long-term cohort data. So we need to follow people for 30, 40, 50 years to really know that for certain. But given the data that we have, and this is not the only study out there, there's lots of other studies that show the same thing. Given the data that we have, our best guess as of right now is that e-cigarettes are, in general, as a class, less harmful, definitely than cigarettes, and might be comparable to NRT. So they also deliver nicotine a little bit more differently than cigarettes. So this is from a recent study, and this down the side here, this is nicotine plasma levels. And then right here, this is time. So what they did is they had people come into a lab and use an e-cigarette in a controlled manner, and then took blood from them at 5 minutes, and at 20 minutes, and at 35 minutes. And so what you see here, this green, this is a cigarette. So you can see, like 5 minutes after you start smoking a cigarette, your nicotine levels in your blood go way up, right? That's why people find cigarettes so reinforcing and so hard to quit, because you get a rush of nicotine immediately. You know, the thing that we say in tobacco control, right, is that you feel the hit within 7 seconds of your first inhalation. With e-cigarettes, they're a little bit different. So you see this red line. It does eventually achieve plasma levels, nicotine plasma levels of a cigarette, but it takes 35 minutes. And this is for a new generation device, or a second generation device, those ones that look like markers.
Is this just for one hit?
No, they are doing a controlled bout. So they're taking, I think this is from, I think it's 10 puffs. Okay. But don't quote me on that. So they reach levels of comparable to cigarette smokers, but it takes a longer time. So this is one of the reasons why addiction scientists hypothesize that e-cigarettes are not as addictive as cigarettes, because you're not getting that drug hit all at once as quickly. The quickness of drug delivery is one of the things that predicts how addictive a drug will be, how quickly you feel the subjective effects of the drug. And then you see the little cig-alike, the little devices that look like cigarettes, they never get to the point of a cigarette, and they just kind of, they're not doing so great. So you can see how maybe a cigarette smoker who is trying to quit might not find these little cig-alike e-cigarettes particularly useful. So who is using e-cigarettes? This is from CDC. So this is from, I believe, 2014 data. So this is 2014. So in 2014, 12.6% of adults had ever tried an e-cigarette. And then of that 12.6%, the majority, 55.4%, are recent former smokers, meaning they quit in the past year. Second most, 47.6%, are current smokers. 8.9% are long-term former smokers, and 3.2% are never cigarette smokers. And then if we look at who is currently using e-cigarettes, meaning any use in the past 30 days, we see 3.7% of US adults in 2014 were past 30-day users. Of that, 22% of that 3.7% were recent former smokers. 15.9% were current cigarette smokers, 2.3% were long-term former, and 0.4% were never smokers. So what does this suggest to me? This suggests that there is an association between being a former smoker, a recent former smoker, and e-cigarette use, current and ever. I cannot tell the directionality of this association because this is cross-sectional data. So I can't tell if quitting smoking came first and then they started using e-cigarettes, or if they started using e-cigarettes and then they quit smoking. But I do think that this is interesting and suggestive of a relationship. We also have a recent study from some people at UC San Diego. They did some really interesting work with some population level data, and I have their conclusions drawn out here. So let's first look at the figure. This is figure from the current population survey tobacco use supplements. So this is the quit attempt rate, and then the annual cessation rate. So obviously, higher quit attempt rate will lead to a higher annual cessation rate, right? Because you have to try to quit before you quit, at least theoretically. So you see, it's pretty flat from 01 to 03, 06 to 2010. And e-cigarettes were rare, really in 2009, 2010, 2011. They really started taking off between, I'd say, 2011 and 2014. So you see there's a little bump here in quit attempts, and there's also a little bump in cessation. And then when they looked at just the 2014 data, and they stratified by whether or not someone had used e-cigarettes in the past 12 months, they see a big difference both in quit attempts and in actual cessation. And once again, we can't say for certain that's because they were using an e-cigarette, but this is, again, suggestive that e-cigarettes and cessation and quit attempts are associated in the population. So this is among adult smokers. But what about the kids, right? So we hear so much about kids using e-cigarettes, and it makes a lot of the news. So the main concerns about e-cigarette use in youth. The first one is that e-cigarette use is harm enhancing for youth and really for all non-tobacco users. That is absolutely true. While they're not as harmful as cigarettes, they are harmful. They're not harmless. They're not just water vapor. So if you consider they are harm reducing for adult smokers who are unable or unwilling to quit if they switch completely, right? Partial switching is not going to do it. They have to switch completely. But they are harm enhancing for people who are not using anything. There's also some concern that nicotine might be a problem for the adolescent brain. It might prime them to be more responsive to other substances of abuse in the future. It's kind of up for debate about that, but it's best just precautionary principle. Let's just go ahead and say best guess. Just avoid it. The other concern is that e-cigarette use is a gateway to more harmful forms of tobacco use, namely cigarette smoking. This is a very difficult question to answer with observational research. You are not going to do a randomized controlled trial where you're going to get a bunch of kids and randomize half of them to e-cigarette use and half of them to non-e-cigarette use and then see what happens, right? So that's not going to happen. The data is absolutely all over the map on this. And the conclusions depend on the definitions of exposure and the outcome. So it depends on how you define e-cigarette use, depends on how you define cigarette use. And so what I think is most useful right now is we don't really need to know if e-cigarettes are a gateway to anything. Who cares? For me, we should think of e-cigarettes perhaps as a marker of future risk behavior, right? So if you're a clinician and you find out one of your patients is a kid and he's using e-cigs, you might want to be like, okay, what else is this kid getting into, right? Because what we're seeing is that well, my hypothesis, I guess, is that it is the lowest consequence harm risk behavior that kids have found right now. It's really easy to sneak. You don't smell like anything. So my theory is they're playing with some risk behaviors. And so if you find this out, you kind of know this kid might be pointing in the direction that you don't want that kid to go in, right? And so, as I said, who cares if it's a gateway or not? I mean, let us scientists try to figure it out. But for application purposes, kids should not be using e-cigarettes. It doesn't matter if it's a gateway, right? Just boom. That's all you need to know. So just to also kind of orient you to the population level data, this is trends in past 30-day use, which is often considered current use for kids. For cigarettes and e-cigarettes among high school students, and I updated it with 2016 data. So you see, in 2011, cigarette smoking was way up at almost 16%. E-cigarette use was down at 1.5%. And then as e-cigarettes became more prevalent in the adult population, we saw kids using them more too. I mean, where do they get them from? They get them from adults. Also online. So this change right here, this is some inside baseball news for you all. This change is probably not real. The National Youth Tobacco Survey changed the way it asked about e-cigarettes between 2013 and 2014. In 2013, they said, hey, tell us what other tobacco products you use, and they had a list, and it was just check all that apply. And in 2014, they asked, hey, have you used e-cigarettes? Yes, no. They also made that change for hookah, and if I put hookah on this, you'd see the same thing, this huge increase in prevalence of hookah use. And this is a well-known survey design thing. When you ask when you ask these questions differently, you get different prevalences. So I think this number is correct. I don't think this change is correct. It was probably more like this, right? So we were probably underestimating use in 2011 and 2012 and 2013. And now we're more at the right prevalence estimate. So could you erase all my scribbles? Yeah. Okay, thank you. So, so what you're seeing is, yeah, e-cigarette use took off. 2015, it outperformed cigarettes. What we're seeing is also really good news for public health, because the thing that is causing the most harm is continuing to decrease. And if e-cigarettes were a gateway to cigarette smoking, I would expect, you know, here it takes off, I would expect this, whoops, I did not mean to do that, sorry. I would expect, oh my goodness. Anyway, I would expect an increase. Now, it could be that this line should be more like that, though probably not that dramatic. So it could be that e-cigs are a gateway, and this decrease would have been more dramatic without e-cigarettes on the market. We can't know for certain. But certainly what we need to be doing is keeping an eye on this, keeping an eye on prevalence of cigarette use and e-cigarette use. And we need to make sure that this doesn't start to tick up, at minimum. Okay, and then also, I just want to make a quick point here. You can look at this. This is the source, publication from my colleagues and I just want to make the point that when you see a distribution, so this is the frequency of use in past 30-day cigarette use and e-cigarette use. When you see a bimodal distribution like this, where there's a lot of use in 1 to 2 days in the past 30 days, and there's a lot of use in past 30 days, and then there's kind of a lot of incidental use right there, that suggests that, you know, these folks are experimenting, these folks are addicted, right? What you're not seeing for e-cigarette use is that. You're seeing a lot of experimentation, and you're not seeing a lot of past 30-day use. And among the past 30-day users, the 90% of the past 30-day users are also using other tobacco products. So there's very little past 30-day e-cigarette exclusive use. So if you also see a kid, if you're a provider and you see a kid who's using e-cigarettes, that kid's probably using other tobacco products, almost certainly. So yes, in summary, it's complicated, right? E-cigarettes are complicated. And really, for me, the question is, how do we use policy and product regulation to amplify any positive effects and eliminate any negative effects of e-cigarettes on public health? And yep, it's hard, it's complicated. And we could ask similar questions about other consumer products, right? So we could ask those questions about alcohol. The majority of people can use alcohol without a problem, but for a subset of people, alcohol causes major problems. So how do we regulate a product that has different effects on different populations? Marijuana. Gosh, we'll see. We'll let you know in a few years how that goes. Prescription opioids. We're well aware that there is a huge problem with opioid abuse in our country, right? But also, these are products that are extremely useful to people who have chronic pain. And even think about automobiles. We need these things to get around and live our lives, but when used improperly, they can harm or kill us, right? So we need to figure out how to use policy, law, and product regulation to make all of these consumer products as good for us as they can be and to minimize negative consequences of their use. And here's something interesting. So FDA recently announced a couple months ago that they want to reduce the amount of nicotine in cigarettes to a point where they think there's some sort of sweet spot where nicotine will be, cigarettes will be not particularly addicting for people who are starting, and so it'll be easier to quit. But you notice that this picture here, this is not of a cigarette, this is of an e-cigarette. Because at the same time that they said that they wanted to decrease nicotine in cigarettes, they also said they want to, for people who are having a hard time quitting, they want to make lower harm products containing nicotine more available. So that's very interesting to me. What they're saying is, we want to stomp using policy on the thing that causes the overwhelming amount of death and disease in our country, the cigarette, the burnt tobacco. When we want to see if we can move millions of people from the high harm product to either no smoking, ideally, or if they can't do that, instead of them going to a black market, we'd like to see them use a low harm product that still has nicotine in it. And I think that's a very, very interesting idea. It'll probably take years to implement because companies will sue like crazy. And what you actually saw is this is Altria's stock price, and this is British American Tobacco stock price. Altria, AKA Philip Morris, they changed their name a few years ago because they thought, you know, people don't like Philip Morris, and they're right. And what you saw is after FDA made their announcement, their stock price plummeted. Same thing in British American Tobacco. And to me, when you see that, it's usually good news for public health. So in summary, e-cigarettes' ultimate effect on public health is complex and evolving, as I think I've hopefully made the point. We can use policy and regulation to force companies' priorities to align with ours in public health as much as possible. And the challenge, the public health challenge, is how do we allow smokers to pursue quitting in whatever way gets them there? I do not care how you quit. If you need to stand on your head for 20 minutes a day and do the Macarena, and that gets you to quit, fine. If you need to put on a patch and use an e-cigarette and use varenicline and go to Fiji, I quit. That is the number one thing. I do not care how you get there. Because the thing is that when adults quit, fewer kids quit, fewer kids start smoking. Essentially, it changes norms, it changes supply of the product in the population. So we need to support adults to quit and however they want to get there, while simultaneously avoiding attracting youth to e-cigarettes. And I put this circular firing squad because if any of you are in tobacco control, you might know that we've had a lot of debate about e-cigarettes and their role in tobacco control and public health. And I think we're doing ourselves and smokers and non-smokers a disservice when we waste all of our time debating things like gateways, when in fact all we need to say is kids shouldn't use e-cigarettes and adults should quit. So let's get this number down to 0. How about it? And I thank you for your attention. Please do email me if you'd like to talk some more. Thanks.
Do we have any questions? I've seen the chat going on. We did see a question earlier. So if someone uses an e-cig with little or no nicotine just to control the need for something in their hand, is it less dangerous than smoking tobacco products?
Yes, it is.
Do we have any other questions? Please feel free to unmute yourself with the icon in the lower left corner of your Zoom screen or send them in via the chat.
I love questions. And feel free to challenge me if you, I have a feeling that for some of you this might be new and surprising to hear someone, a tobacco researcher, say e-cigarettes aren't terribly bad for you and smokers who are unable or unwilling to quit should switch. So please do challenge me. I love challenges.
What about the difference in milligrams?
Right. So you're asking about nicotine concentration. So the question is, what about differences in milligrams? So I'm going to interpret that to mean you're asking about different nicotine concentrations. So different products have higher or lower nicotine concentrations. Remember that nicotine is not the thing that's particularly harmful. So nicotine's in the patch. You can buy it over the counter, right? So different products have different nicotine concentrations. The smaller products with the smaller batteries have higher nicotine concentrations because they don't do as good a job delivering nicotine. So they need to have more nicotine in it to get it into you. People who have those really big devices that look like pieces of electronics, those can have much lower concentrations of nicotine because they do a better job delivering it to the lungs. So, a higher nicotine concentration is not inherently more or less harmful. You know, it is an indication. Someone who was like a heavier smoker might want a higher nicotine concentration than a lighter smoker. Nicotine itself is adversive, so if you get a lot of it, you feel queasy, your heart rate starts to pound. I don't know if anyone saw Thank You for Smoking. It came out years ago, and one of the jokes in it was they were trying to kill a guy by covering him in nicotine patches. That's theoretically possible. In fact, there have been some poisonings from nicotine fluid that didn't have child-safe caps on it, and that's a big problem. Clearly something that could be addressed by regulation. So yeah, I hope I answered your question.
We have another question. Does vaping or e-cigarettes cause popcorn lung?
Ah, good question. So yeah, this is a big thing that came out in the news. I'm aware of one case of popcorn lung from vaping, and that is from that flavoring that gives like a buttery flavor. So this is another obvious opportunity for regulation. That flavoring that has caused popcorn lung, and I don't know what his exposure was like, but I imagine it was pretty heavy. Should absolutely not be in that product, right? That should be. We should use regulation to remove that. That is once again, like I said, low-hanging fruit. But when you think about, yes, you know, there was one guy that was, maybe there might be more people. I am aware of one case study. That one person, that is unacceptable, but at the same time, when you can compare it to the 480,000 people from tobacco, you know, it's dwarfed. I think my point is, e-cigarettes are not harmless. They're harmful. And, you know, you've seen on the news the batteries exploding, and yeah, these things happen. But they happen, the negative effects happen at a much lower rate than cigarette smoking, which happens every day, every hour, every second. Yes?
So there's another one. Do you think it's possible to sway adults without swaying kids? This seems a bit difficult to do without perpetuating the image of smoking. When kids see smoke, they think it's cool.
Yeah, so good question. So in the UK, they have taken a very different approach to e-cigarettes. So they have an explicit harm reduction slant to their National Health Service, which I guess makes sense. They have a National Health Service, right? So they're trying to decrease costs. They have this thing called the Nudge Commission, which is trying to kind of slowly affect people's behavior without them realizing. And what they have been doing is actually actively promoting e-cigarettes to people who call the National Quit Line. And they have seen significant drops in cigarette smoking without increases in youth smoking. And the way that they've done that is they have seriously controlled access to these products, so they have strong age controls. I would love to see tobacco 21 laws in every state in the country. Right now there's only a few states that do that. And I would like to see those applied to e-cigarettes as well. And I think that we can frame these devices as crutches to help you stop smoking, right? And I think, I can't speak for kids. I don't know what they think is cool or uncool. But I think if we're able to speak honestly about these products as a thing that people who are smoking can use to quit, and not as a cool, fun thing you use at parties, I think we can do it. The UK is doing it, you know. And now here I'm going to be super controversial. How many kids are we willing to allow to start using e-cigarettes in exchange for adults quitting? I don't know. But the reality is that on a public health level, we're not going to have a situation where absolutely zero kids are going to use e-cigarettes, right? It's just, that's not the reality of public health. So my feeling right now is that we use all the stuff that we know works in tobacco control. We continue to tax, we continue to regulate, we use warnings, we use media campaigns, we get tobacco 21 in every state. We make Chantix or varenicline over the counter, which is something that I'm working on, which is the best treatment for smoking that we know. You know, we make NRT more accessible. We do all of these things. But perhaps we also say, and hey, if you can't quit any other way, use e-cigarettes. And then once we get to the point where smoking is a very low prevalence situation, then we focus on e-cigarettes. Then we say, okay, let's get rid of these things too, because they're not harmless and now they're causing a problem. But we have limited resources in public health. And I really feel strongly that we need to focus on the thing that causes almost 500,000 deaths every year.
So Dr. Bayan asked, if a patient comes in and says they smoke a pack a day, how many milligrams is the equivalent for an e-cig?
That is hard to say because it depends on the device. So definitely that person shouldn't be using the little devices, the little cigarette-looking devices. But that person could use the second generation device with a nicotine concentration of like 1.8 milligrams per milliliter, or they could use one of those big devices where it's like 6. So it really depends on the device. What I recommend, and this is going to sound crazy once again from a public health person, is that smokers who want to quit, go talk to smokers who have quit using e-cigarettes and see what their advice is, see what their process has been. And a lot of those people are utter evangelists about e-cigarettes. They're saying, you know, this thing saved my life, and they are happy to talk about it. So that's my advice.
Kelly Goatley Seals from the state said that there was a recent study by PRI talking about the aldehydes in E6 from the flavoring. Are there any other harm markers that you didn't discuss today? Yeah,
so there's a few things. So there's a well-known formaldehyde study. There's they produce particulate matter, PM 2.5, which you definitely don't want to be inhaling. Once again, not harmless, right? There is absolutely harm associated with these things. So let's see, acrolein, acetylcholine, formaldehyde. Yeah, I mean, some of them have TSNAs in them, but once again, in almost every case, there are much lower levels than cigarettes. The famous formaldehyde study that came out from some people, I believe at UC San Diego, or maybe San Diego State, they essentially, what they did is they really kind of like burned an e-cigarette. They cranked it up to like its highest ability to produce heat, and then had little to no liquid in it, and then were able to produce a lot of formaldehyde off that product. And kind of the metaphor that I use is like, imagine you put a piece of toast in a toaster and like you crank it up to its highest setting, and you put it down. And then when it wants to come up, you like put it down again. And then when it wants to come in, you put it down again. And then you go, here's your piece of toast. And like, no one would actually want to eat that piece of toast, right? It's burnt. It tastes bad. And that's the same thing. So that product, people are probably not inhaling that amount of formaldehyde because it's aversive, it tastes terrible. But it's not acceptable that that product can produce that amount of formaldehyde. It's not okay. We can use regulation to put guardrails on these products and make sure that they're not able to produce toxic levels of anything. It's the beauty of regulation.
And then same question from a couple people, secondhand.
Secondhand, okay, so yeah, that's a big thing. Depending on the setting of the e-cig, sometimes it's super visible, right? They can produce these huge clouds of aerosol. I am not aware of any studies. Whoa, there's some crazy stuff going on next door.
Autism.
Oh, okay, all right, sorry. So I'm not aware of any studies that have shown negative exposures from secondhand vapor. So the last study I remember looking at, they essentially put a person in like a column, like a glass column pump full of aerosol, and they were able to detect some nicotine in that person's blood, but they weren't able to detect any other biomarkers of harm. And that's probably because if you think about a cigarette, there's always side stream smoke, right? Because it's burning, it's always burning. With an e-cig, that doesn't happen. It only produces aerosol when you take a drag off of it and then you exhale. And it's an aerosol, so it dissipates pretty quickly. It kind of falls to the ground. So I guess what I'm saying is the data is not supportive that secondhand aerosol is particularly harmful. The best advice, though, is that certainly pregnant women and kids, especially infants, and people with respiratory disease should not be exposed to this because there might be some harms that we just haven't gotten to yet. And I think best case scenario is that it should not be allowed indoors just in general. I am more ambivalent about multi-unit housing. I'm very supportive of smoking bans and multi-unit housing. I'm not convinced that e-cigarette aerosol can travel far enough for it to affect neighbors in multi-unit housing. So, but I'm open to science that would suggest otherwise. That's just my best guess right now. All of this is my best guess, by the way. As things come out, you change your ideas, right? And that's what happens when you're a scientist. Okay, so I think we're over time. So, are we done?
Good, yeah.
Okay.
Thank you so much, everyone, for joining us today.
Bye. Thank you. Email me.